take water up here? Good morning. And thank you, Dr. Rice, for that very kind introduction. And thanks to all of you for coming out this morning to hear this lecture. Really appreciate your support and attention. And I'd like to also acknowledge my colleague, Dr. Juan Luque. We actually collaborated about 10 years now, back in 2007 when I was at Moffitt Cancer Center, as well as himself. So I'm excited to be here to share some of my research with you. I'm just going to share a portion of the research that I've been working on probably for the past 10 years as it relates to prostate cancer. Dr. Luque and I did quite a bit in the screening space, but what I'm going to present this morning is more from the point of diagnosis through survivorship. So just as some disclosures, I currently serve on the National Advisory Council on Minority Health and Health Disparities as a council member, as well as I serve on the Minorities and Cancer Research Council for the American Association for Cancer Research. So just some background data to help us frame this issue that we commonly refer to as cancer health disparities. Now, as you can see in this ACS depiction, cancer does not proportionally impact all individuals, but some populations are disproportionately impacted by this disease. As you can see, non-Hispanic blacks, based on gender, black men are more likely to be diagnosed with cancer in comparison to men of other racial and ethnic groups. And then secondly, you see non-Hispanic whites, followed by American Indian and Alaskan Native, and then Hispanics. And then in regards to women and their cancer diagnosis, you can see that non-Hispanic white women are more likely to be diagnosed with cancer in comparison to women of other racial and ethnic groups. Now, when we look at mortality, the story changes a tad bit for the impact of cancer. For men, you see, for non-Hispanic black men, they, again, are more likely to die from cancer in comparison to men of other racial and ethnic groups. But it's switched. Now we have non-Hispanic black women that are more likely to die from cancer, although they are less likely in comparison to non-Hispanic white women to be diagnosed with cancer. So there's something going on from the time of diagnosis to the time of actual presentation for treatment. But the good news is, in the context of prostate cancer, we're making great progress. Today we can boast about, we have nearly 3 million prostate cancer survivors. And the mortality for prostate cancer is continuously on the decline for all men, especially African American men, where there's, over the years, been a disproportionate impact of this disease. Although the disparity remains, the numbers are on the decline, which is good news. And it really points to the story that we are making progress as it relates to really addressing this gap and this unequal burden of this disease on different populations. So we are, I think we're all familiar with the common side effects of treatment for prostate cancer. The impacts are broad, wide, and steep, and really adversely impacts the quality of life of these individuals, whether it's through erectile dysfunction or urinary incontinence, hot flashes, and the list goes on. These are just some of the commonly reported side effects as a result of being treated for prostate cancer. So over the last decade, there's been quite a few reports that have been compiled by the National Academy of Medicine that really chronicles this whole notion of, okay, what happens once a patient is diagnosed with cancer? There's a sequelae of events that take place that really, really speaks to the poorly constructed infrastructure that we have in our healthcare system for the cancer patient to properly progress through. From information needs to effective coping strategies, culturally tailored interventions from the behavioral, from the educational, also from a dyadic standpoint, which may involve a caregiver. We have a poorly coordinated infrastructure in this country, as outlined in this IOM report, or National Academy of Medicine report, From Cancer Patient to Cancer Survivor. And then subsequent to the release of that report, a second report was released, really advocating for, our focus should not just be on treating cancer. We should not just be concerned with this notion of, let's get this tumor out of this patient. But we need to care for the person as they are, and realizing that this isn't a person, stricken only with cancer, but this person had a life prior to, and a measurable quality of life. And so quality of life became, a key outcome. And over the past I guess, 5 or 7 years, I've been involved in a number of initiatives that really, looked at patient-reported outcomes, because they do matter. Even those who are cancer-free, beyond the cancer, how are you doing as an individual? And are we able to get that individual back to a measurable quality of life? And again, really, in this report that was released in early 2000, around 2002, 2003, again, chronicled this whole notion of cancer disparities, especially in the context of survivorship, and how even after individuals are treated for cancer, it's such a poorly coordinated infrastructure. That, we have poorly constructed delivery care models in community-based settings that often adversely impact and exasperate a lot of the issues that individuals had prior to going into the clinical setting to get their cancer treated. And so, these are very, very real issues when you sit down and talk with prostate cancer survivors. But unfortunately, there's been not many studies really looking at this issue in the literature. And so just as a backdrop, we know that more than 90% of prostate cancers are discovered in the local or regional stages, which is great news, because that means individuals are surviving their cancer diagnosis as it relates to prostate cancer. But despite this great potential for survival, health-related quality of life is often compromised, and it's often not discussed. It's an issue that we say, well, you should be happy, you are cancer-free, going about with your happy life. But if you're suffering, or if your quality of life has changed, or life as you once knew it has changed remarkably, you have to begin to ask yourself, well, is there anything that we can do to help intervene on a lot of these issues, at least mitigate these issues that one is facing? And then being knowledgeable about cancer, we're starting to understand more and more the role of information and information dissemination, and involving individuals in the patient-provider communication, and involving individuals in medical decision-making, taking more of an ownership from a model of empowerment to ensure that they are able to develop effective coping strategies post-treatment, and that their decision-makings are commensurate with them being able to achieve a measurable quality of life prior to diagnosis. Now, we know that there's a host of studies that's being published that really sort of chronicle the unmet needs of many cancer patients from the time of diagnosis through survivorship. And these unmet needs could range from in the domains of communication, information needs, physical needs, financial needs, and the list goes on. There's a number of standardized measures that are currently being implemented that really captures sort of the totality of the unmet needs among cancer patients, especially prostate cancer patients. And we understand that information seeking has been demonstrated to mediate individuals' disruption of quality of life. And again, this model has been tested overwhelmingly in the breast cancer literature, but not much has been evaluated in the context of prostate cancer, looking at the role of information and can it serve as a mediator to quality of life. And I'm going to conceptualize quality of life in a few slides. We know that the benefits of acquisition of information include the improved ability to cope during the diagnosis, treatment, as well as the post-treatment phase, reductions in anxiety and mood disturbances, as well as improved communication with family members. So to help us better characterize the impact of being diagnosed and treated for prostate cancer among a population that's disproportionately impacted by this disease, we set out to do just a small preliminary study, qualitative in design, to really, one, identify the salient psychosocial issues among African-American prostate cancer survivors, as well as their spouses. And so bringing in that caregiver, looking at it from a dyadic design. And then identify the preferred communication channels, including medium tone and appeal for African-American men and their spouses to receive education related to ways to address these psychosocial issues that they may be facing. So we use Betty Farrell's quality of life model to help us conceptualize what quality of life is in the various domains. And as you can see, we added a fourth one, the behavioral well-being, that focused on diet, exercise, alcohol consumption, tobacco usage, as well as health promotion activity. And this particular domain accompanied, the evaluation in the psychological well-being, the physical well-being, social, as well as the spiritual well-being. And so we conducted 24 key informant interviews with not only the patient, but also their reported spouses at the time. And as you can see, we excluded individuals if they did not meet the the listed inclusion criteria. And so our participants, the males, were between the ages of 51 and 70, mean age of about 59 years. Most of the couples reported being married through the diagnosis and treatment process. And we also looked at the length of marriage and evaluated marital strain. And then the most common forms of treatment, as you can see outlined here, 33% reported receiving surgery, 42% reported radiation therapy, with 25% reporting some type of combination therapy. And just real quickly, these are some of the qualitative findings that yielded as a result of our inquiry. As you can see, physical well-being was probably the most cited reference among prostate cancer male survivors, as well as sexually related factors. And as you can see, there's some concordance there with females in terms of what they ranked or more concerned with, physical well-being of the prostate cancer survivor, as well as their sexual functioning. And if we can just really, explore this a little bit further, we can see some of the concordance between the survivor and their spouse, but then also we see some discordance as well. While if you just quickly peruse through the different columns, you see that the survivor tended to focus more on the side effects of treatment, sexual functioning in particular. That was a huge issue. And being able to, one, acquire adequate resources to help mitigate whatever issues they were facing in terms of sexual functioning. But then, two, also who they can communicate to about this issue, or knowing where to go to help bring some level of resolve to this issue. While the spouse was more so concerned with the global picture, being of their spouse being cancer-free. Yes, there may be some issues, but we could address those to ensure that your wellness is in place. And so we see some concordance as well as some discordance views, and we published these findings in Psycho-Oncology. So I strongly encourage you guys just take a look at it if you're interested in just learning more about some of these issues. And then in the area of social support, a lot of the males depended on their spouse for social support, while the spouse depended on their family. And this is interesting because oftentimes a lot of the clinical encounters only entail the survivor. We had probably 90% of the survivors say they went to every appointment by themselves. They never took home any information, their spouses said, and they never shared the information with their spouses. So now we have a situation where a lot of these decisions are being made in isolation by the survivor with their healthcare provider. But then in the survivorship phase, there's a high dependency on their spouse to be their primary caregiver. So how effective can a caregiver be without the right information or the right resources? And then if the spouse is enduring caregiver burden, which is a real issue, and we see that in the breast cancer literature, and if the spouse is looking to their family for support, what is the state of readiness for their family members to help address some of these issues that the caregiver is feeling burdened with? And so again, going back to the IOM reports, it really talks about the flow of information and the need to really decentralize this information out of our clinical settings and maybe look at some novel, innovative, community-based information delivery systems. Maybe a new model of how we disseminate information, evidence-based information, that activates not only the patient, but then also the caregivers around them. That's going to help them progress successfully through this disease. And again, looking at some of the concordance and discordance between the responses of the survivor as well as their spouse. Again, lack of information sharing with the spouse, concern of the lack of communication or not being involved in the process. A lot of the spouses didn't understand what erectile dysfunction was. Some even reported contemplating divorce because they found that their spouse was unable to get an erection and they thought they may have been having an affair. Again, this is what was being reported to us, and these are the real issues that survivors are encountering as well as their spouses, because when you don't have the information, of course, you make, sometimes erroneous assumptions about what is actually going on. And so, and again, we see some concordance, but mostly there's discordant views. And then when we asked the survivors about resources for support, again, a lot of the respondents talked about using people as a source of support, not turning to their clinical provider, not turning to websites or anything, but talking to the people who they trust. that are in their immediate circle. But then the question begs, how ready are these individuals to be able to offer you advice and strategy on how you, deal with these issues? The men were asked if they recalled receiving educational resources such as videotapes or brochures, and the majority did not recall receiving any information about what to expect after being treated for prostate cancer. And then lastly, the respondents did not express barriers or reluctance to the use of educational resources for prostate cancer patients, realizing that some are out there. But there was a request that there was this attention to cultural appropriateness or cultural sensitivity as it relates to the design and the development of this information. They really wanted the materials to speak to them. One, why are they adversely impacted by prostate cancer? And then two, what changes can they make to further prevent this disease from within their family, realizing family history is a risk factor, and as well as really speaking to some of the socio-cultural factors related to being African American. And so when we asked them about the format for educational resources, this is pretty interesting. A lot of them asked for electronic-based materials, something that again was not tied or constrained to the clinical setting, but something that they can take home and share with other family members to properly discuss this disease and the path that they should take, ensuring that their decision-making is commensurate with their support system as well as their understanding of what their quality of life would entail. So in summary, what we found from this qualitative exploration is that the men realize that cancer is a disease that affects the entire family, but then often the community as well, and the community around them. And the role of knowledge across the cancer continuum really emerged as a strong predictor in terms of the level of communication as well as engagement on the side of not only the prostate cancer patient, but also their spouse. The need to identify culturally appropriate communication channels, realizing that we cannot generate information generically for all populations, but we have to deal with some of those cultural nuances that apply to certain populations. And then looking at the role of literacy as well and community-based context for dissemination of this material also emerged as a key finding. And then lastly, the need for targeted educational approaches at the point of diagnosis through survivorship. And that was one thing that we heard as well. Men did not want to be educated sort of in phases. Like, well, this is a brochure about screening, or this is a brochure about what your Gleason score means, or this is a brochure about staging. They wanted education across a continuum to anticipate what would be the outcome. And once they understood what the implications will be in terms of outcomes, then they could make decisions about if screening is right for me, or how am I to interpret this Gleason score? Should I actually go on active surveillance, or should I intervene? And so comprehensive education was definitely advocated and preferred. So with that information, we decided to build a psychoeducational intervention. I had colleagues at the time when I was at Moffitt Cancer Center that were actually working on building psychoeducational interventions in other domains, lung cancer as well as breast cancer. But there hasn't been much research in the area of prostate cancer. And we know that for mediating outcomes and providing psychosocial and supportive care include improved social support. And again, these are emergent themes from our qualitative exploration. Increased knowledge of treatment and disease, improved self-efficacy, as well as service utilization. And we know that psychoeducation embraces several theories and models of clinical practice, which includes ecological systems theory, CBT, or cognitive behavioral theory, learning theory, as well as stress and coping models. And it also reflects a paradigm that is more holistic and competence-based, stressing health, collaboration, coping, and most importantly, empowerment. And again, these are all emergent themes from our qualitative exploration. And we know that educational interventions have been shown to be efficacious, excuse the typo, with prostate cancer patients during diagnosis, treatment, as well as post-treatment. And we know that these interventions varied in design, and as well as in the format of delivery, from videotapes to audio tapes to computers, telephones, as well as group-based educational interventions in community-based settings. And so we set out to design, based upon what we heard from prostate cancer survivors. I mean, who else to ask if you had to go through this process again, what things would you have preferred been in place? And they gave us some great information that allowed us to actually go in and do some intervention mapping, design what we think is a viable intervention that really addresses the needs of not only prostate cancer survivors, but also their caregivers and their immediate family members. And again, just some additional topics that emerged, and also the type of display they would prefer to see this information in. And so we decided, should we do a website? That's been done before, and the evidence is just okay for pushing and pulling information to individuals. We looked at texting campaigns, but then we considered the demographics of this population. And so we decided to utilize the iPad. It's great for community intervention. It has been really demonstrated, in the context of community-based research. But we thought it would be a good standardizer of delivery of community-based interventions. And I'll talk more about that in a few slides. And we realized that the demographics are changing. A lot of people say, well, if you introduce technology to, populations that undergo disparities, aren't you exacerbating the disparity? Don't you know that there's technological disparities? But when you look at the data, look at the Nielsen data here, for example, among smartphone ownership, African Americans, 83% are African Americans. Is that surprising to anybody? Are you guys familiar with these demographic trends, the uptake? Yeah, I see a couple of heads shaking. Yeah, this is surprising. So, when I'm at these scientific meetings and people say, oh, you just need to keep it plain, need to keep it simple, do something like a brochure or a poster. People are not utilizing smartphones or apps. But the data says differently. And then even when you look at some of the Pew Research Center data, and you look at how are people using their smartphones, look at the top one, to get info about a health condition. Is this surprising to anybody? No? How many people use their phone to get health information? Oh, wow. Really? From where? Through apps or through the internet? Internet? So how do you know a credible website, though? Because there's no ranking of the websites. How do you know that's evidence-based information?
Well, I use WebMD. I know it's not very reliable, but
Okay.
sometimes it does give you
Good information. Well, WebMD is a standard. Yeah. Okay. So that's a check. Name recognition. Any .gov. CDC. Okay. So that's an easy website. CDC.gov. Right. NIH is a little bit more complicated. You have to put nci.nih.gov, and it's a little complicated in navigating. You were gonna? NIH as well. That's where you go for health information. Anybody else? So people are turning to other sources. It's not the usual source of how one acquires information. And so in the health arena, I think we have to consider that new platform that exists. I do everything from this, from checking my bank account to paying all my bills to even buying gas on here. You can buy gas. And so how can we leverage that in the health sector as it relates to really advancing some of these issues that we know aren't being achieved in the clinical setting? It's not because physicians don't want to. I'm not blaming physicians, but there's time constraints where they can't do everything. And for some, and we had a study before looking at this whole notion of informed decision making. How does that look? Can anybody characterize that for me? Is that a 20-minute conversation, or is that a 2-week conversation? And again, so we have these recommendations that are made, but oftentimes we don't characterize them to a practical delivery model. And so that's all we're proposing to do as it relates to addressing a lot of those emergent themes from our qualitative exploration. So we ensued with a 3-phase process to develop an app. And we collaborated with the Florida Institute for Human and Machine Cognition. Moffitt Cancer Center was their first sort of lay or non-government entity that they worked with. Historically, they only worked with NASA and getting the astronauts up to the moon. And so it was very unique in terms of how they approached this whole notion of cancer and the complexities around cancer. And so they helped us create this knowledge model, which is a collection of interconnected concept maps and associated digital resources about a particular domain. here's the methodology that we used. We started off with, again, our formative research findings. We did a review of the NCCN guidelines for patients within the domain of prostate cancer. Then we also reviewed the National Cancer Institute website. And then we conducted knowledge elicitation sessions with physicians as well as with prostate cancer survivors. And then we generated a set of concept maps. And what are concept maps? Was basically a display of information in a non-linear format. And so it's a new approach to how we present information, and undergirded by the theories of knowledge as well as learning. And then the resources, because again, these were some of the things that we heard in our focus groups. Individuals are diverse learners, so they just don't want to read all the time, but they may want to see a graphical depiction. They may want to see an infographic. They may want to hear the physician, because the physician is still the preferred health educator for most patients. So we don't want to lose or negate that voice, but how can we decentralize it out of the clinical setting and still deliver it to patients so nothing is compromised in the process? So here's an example of a concept map. That's Dr. Julio Pausing. He's the chief of the GU at Moffitt Cancer Center. And then there's Rich Rosheim, who's a family medicine doc. And each of those little icons under each of the blue boxes represent some type of digital resource, whether it's a video, 2 to 3 minute clip, whether it's a YouTube, and again, we vetted this by experts, so everything on here is evidence-based, whether it's a link to NCI, whether it's a link to NCCN patient guidelines, whether it's a link to ACS, whether it's PDFs for the scientific ones who really want to see how the evidence was generated. We gave them all the information, one-stop shopping as relates to information acquisition around prostate cancer. Had a search capability also embedded within the app. And again, those are some of the topics: prostate cancer, prostate 101, prostate screening, diagnosis and treatment, imagery, and the list goes on. And so what we did after we once developed this app, we just decided to leverage some funding to look at its acceptability. Even though we did develop this with the community, we wanted to make sure that it was acceptable to the community, one, and then two, that the community would actually use such a product. Realizing that some of the issues around communication inequalities include access, the display, as well as how the information is presented, those that are active seekers versus passive seekers of information, and then how the information is processed, which again is contingent upon the display of the information. And examining this within the framework of a social ecology model, realizing that, again, it's just not the individual that we should focus on, but at least 2 additional layers at the interpersonal as well as the community level, because these are all sort of these macro forces that impact the individual's behavior, especially as they progress from being from the point of diagnosis through treatment as well as survivorship. And this is just our multi-level intervention framework that sort of guided us through this process. And again, just your typical guiding research principles about the role of the community and the impact of the community and why interventions should be vetted through the community. And we utilize the CBPR framework to help us evaluate the acceptability as well as the usability. And this is just the process model of our process that we ensued. And so, not really trying to push this technology on individuals, because it could be complicated, it could be overwhelming, especially with all of the considerations of a prostate cancer patient upon being diagnosed with such a disease. And so we decided to look at models of, again, delivery in non-clinical settings. And so we took an iteration of the patient navigation model. How many are familiar with the patient navigation model? There's a few? Okay. What about community health workers? What about promoters? CHAWS? Okay, all right. So it's the same principle and design and scope of utilizing someone. You call an individual out from the impacted community, you train them, and then you place them back in that community. Because what do they have that most people don't have, or most scientists or clinicians don't have? Trust. They have relationships with the community that we don't have. That would take us years to develop. So if you get a gatekeeper or a stakeholder from an impacted community and you train them on some of these issues, of how to overcome logistical issues or knowledge gaps as it relates to a particular disease, and then place them back in the community, now you have a resource. And that goes to the sustainability of a particular intervention, because this person, once the grant is over, once the funding is gone, they remain in the community. Certified as well. We utilize Harold Freeman's Patient Navigator training program to actually certify individuals to serve in this capacity, to attest to their core competencies of the navigation model. But again, applied not in the clinical setting, but more so in a community setting. So we decided to utilize that model and put the iPad in their hand to then go and interface with patients as well as their caregivers. And this model has been tested again in the breast cancer literature. I think Dr. Electra Paskett, she did it quite a bit of work around mammography screening and the uptake of screening among Appalachian women. And a few others are starting to demonstrate a very similar model. And I think the strength of such a model is that it helps us standardize what is going on in the community. For so long, we've been comparing apples and oranges as it relates to community-based research. But this technology gives us a way in which we can standardize and ensure that everybody is getting the same thing, and we're able to achieve maximum fidelity to the protocol. And so what we set out to do is to understand the acceptability as well as the usability of our knowledge model on prostate cancer delivered via mobile tablet technology using concept map software among an adult sample of African Americans. And this is just our acceptability methodology standard. It's been well published in the literature that we just adopted for our study. Excuse me. And we use these 5 questions to evaluate or to develop or derive our mean acceptability score. 1, have you used an iPad before? 2, overall, how easy to use was the iPad? Do you feel comfortable? How does the iPad compare to paper? And then, would you prefer an iPad to complete surveys? So our demographics, we had about, a little over 100 folks that actually responded and participated in this study. You see the breakdown in terms of college. Mostly were highly educated, or at least a college degree or above. Married, under the age of 60, reported an household income of under the age of under 48K. And as you can see, those who had a bachelor's degree or higher were more likely to report satisfaction with the iPad as well as the app, and those with an income of greater than $48,000. But as you can see by the means, the means look great for both groups in spite of the significance in education and income. And so realizing that African Americans are disproportionately impacted by prostate cancer across a continuum of care, there is a need to increase availability of educational psychosocial services. We think, based upon our acceptability study, that mHealth interventions provide the opportunity to standardize and deliver relevant health information, and most importantly, it is accepted by this disparate population. And so in terms of our usability tests, we followed a very similar methodology. We adopted a survey that has been very well published within the usability space. We had an N of about 53, 30 males and 23 females, all African American, between the ages of 18 and 59. And again, we utilize community health workers to recruit them from different community-based settings. Again, understanding the value of the community and allowing us to achieve the whole notion of cultural sensitivity and cultural appropriateness. And the questionnaire was divided into 2 sections. The first section looking at the ease of use of technology, and the second section looking at the use and acceptability of FIN, the application itself, and they were on a Likert scale. As you can see, overall, the participants found both the iPad as well as FIN very easy to use with no statistical differences between them. The results demonstrated that overall participants, regardless of their education, their income levels, and race, found that both the iPad and the app was easy to use without the need for additional training for FIN. So that's good news, because my fear was that our results would say otherwise, and we would then have to go and tailor apps based on one's education status, or go and tailor the app based upon their income. But the technology worked for all individuals. There was no difference in terms of education. There was no difference in terms of one's income status or one's employment status or even one's marital status or even age. And so that was good news because it would have been a nightmare trying to create apps for all those different groups. And our findings indicate that FIN can be effectively used as an intervention tool for all prostate cancer patients, their caregivers from diverse backgrounds. And again, more than 80% of the participants agreed that the FIN app was easy to use, although more than 60% was unfamiliar with concept maps. And I must admit, I didn't know what a concept map was when we sat down at the table to form our collaboration. But through education and practice and exposing the community to this concept map, it went over well, surprisingly. And then more than 80% of participants agreed that the mobile tablet technology was easy to use. So with that, we wrote for R01, and we were awarded an R01 in 2014 to further build upon this intervention and bring all the different components together. But we decided to add a different element to it that we had not examined before, and it was this whole notion of stress and anxiety around being diagnosed with cancer. A lot of us know that it's resident. It's a very stressful moment for most individuals who receive any diagnosis of cancer. But, men, we're a unique breed. So when something strikes us, it's the end of the world, right? And so everything stops, and we need to get all the answers immediately. Until then, we're going to go through some psychological changes. And again, this is well validated in the current body of literature. So the greater the perceived stress and the longer it endures, the lower the telomerase activity. These are some of the biomarkers that we're adding to this entire model to really examine the role and impact of our psychoeducational intervention. So we have self-reported data about the impact of this intervention, but we want to introduce this notion of biological plausibility to see if it's really functioning in the way that it's intended to. We know that chronic stress shortens telomeres, reduces T-cell function, increases pro-inflammatory cytokine responses. Mechanisms for these consequences, however, remain unclear. Tailored psychoeducational interventions have been found to significantly reduce anxiety, overall distress, as well as depressive symptoms. And again, referring back to the breast cancer literature, how much work has been done in this space as it relates to prostate cancer. And so the path remains unclear, but we know stress on the brain produces an increase in cortisol as well as other hormones secreted by the adrenal gland. And when we have a high secretion of cortisol, these are just some of the effects of cortisol on the body. Decreased immune system, depression, hypertension, hunger, hostility, acid reflux disease, and the list goes on. And so what does that do to the tumor environment if one has cancer? Well, as you can see, the immune cells, the immune response decreases, the natural killer cells decrease, cancer cells are able to metastasize, blood vessels, angiogenesis, and cytokines. So it's like a perfect storm for cancer to really magnify and metastasize the tumor microenvironment. And then again, looking at telomeres and the shortening of telomeres under stressful conditions and how it impacts cell division and cancer cell division. So what are we going to do? So we set out to evaluate the impact of, again, our app on quality of life outcomes, among African American men newly diagnosed with prostate cancer. As well, we want to investigate the mechanism, the pathway by which our app actually improves quality of life among African American men newly diagnosed with prostate cancer. Then we would look at a few moderators as it relates to clinical factors and information-seeking behavior. And then, again, the last aim, our exploratory aim, really introduces this notion of biomarkers. And can we really validate the impact of our psychoeducational intervention by seeing changes in cortisol levels as well as telomeres. And that concludes my presentation. So in 2020, you can invite me back, and I should have results from this study. All right, any questions? Sure. The slides? Sure. Dr. Rice, I guess.
We'll make the slides and the presentation available on our website for Dream, so we'll upload everything, literally the entire
And both apps are actually in iTunes as well. Actually, we have 3 apps in iTunes, free of charge. And all 3 of them are from previous studies. Of course, we're not going to put this one in iTunes because then it'll serve as a confounder for the study. But I'll make those available also. And I'd love to get your feedback on the apps also, if you guys find utility in them. Dr. Luque.
Yeah, great. It's wonderful having you here and talking to us. I had a question, two-part. The first part is just like a yes, no. Is there any difference between the watchful waiting group and those who are going through some type of treatment for prostate cancer as far as coping behaviors and stress? Has there been any research
Sure.
on that?
Yeah. So there's been a couple of studies that actually examine the active surveillance group, and anxiety is high among those on active surveillance in comparison to those who decide on an intervention.
It's higher?
It is higher among active surveillance groups.
Okay.
Yeah.
So I want to know if you were going to...
And I'm sorry, are you guys familiar with active surveillance and what it entails? So it's actually a process. Once you receive a diagnosis of prostate cancer, and I guess the complexities of prostate cancer is that clinically we cannot differentiate those tumors, those type cancers that won't cause any problems versus those cancers that are lethal and metastasize really quickly and that can kill you. And so there's a lot of work being done in the prostate cancer space looking at biomarkers to ascertain progression, if this cancer is lethal or if it's more of a latent cancer and you'll die of something else before you die of this cancer. So this heterogeneity in terms of how prostate cancer is presented is what's causing so much controversy from screening all the way through treatment. And to date, there's been no RCT done looking or examining or comparing modalities for localized disease. So comparing if radiation therapy is better than surgery for those with localized disease. And so it's up to the patient to decide what's best for you. So if you go to the urologist, of course, you know they're going to tell you surgery. And you go to the rad-onc, you know what they're going to say. I'm sorry? Right, I'm sorry. Radiation therapy, right. So where's the role of the patient in this process? And what does the patient want? And, you know, and a lot of good physicians sit down and they spend time, you know, that they really don't have to try and educate and help the patient make this complicated decision. And some, after hearing the education from their providers and seeking counsel through their family members, decide to go on active surveillance, which is a management strategy that allows one to maybe, every 6 months to 12 months go and get a PSA to allow one to trend to see if, you know, there's any changes over time, looking at PSA velocity, looking at PSA density, and looking for these type changes to see, is the cancer growing or is it just remaining the same?
Actually, biopsy is what
Yes, it is. Yes, that is one. Yeah, biopsies as well. But they're not as frequent, are they? And we have an expert here. There are
12 to 18 months.
every 12 months, and the infection rate for biopsies is about.
So if the risk goes up or the percent of the positive score goes up,
Right.
then there's a new, the physician and the patient
Right.
get together and decide, so, you know, these are the options.
Right.
There are now also additional tests that may
Right.
seem to have better predictive value. These are very new, something called Polaris.
Mm-hmm.
That looks at individual biopsies.
Sure.
Tests for the expression of certain genes, which may prognosticate whether or not the cancer is more invasive or less invasive.
Yeah. And so, how often are the biopsies completed?
Well,
They're less frequent than the PSA, right?
actually, the PSA, I mean, blood tests, which
Sure.
are invasive.
Yeah, it has limitations.
6 months is certainly acceptable. But
Sure.
biopsy, of course, is an invasive procedure.
Right.
So at least 12 months.
Yeah. And then the infection rate for biopsies, last time I saw, was around 30%, and that's what drives the anxiety in a lot of the surveillance groups, right? Because the high infection rate of the biopsy.
Well, also the fact that there is this idea that the cancer is still inside. So
And that, yeah, so that's what's actually driving the anxiety, having to go through the PSA every 3 to 6 months, having to go through a biopsy at least every 12 months, and then knowing that you may have cancer growing inside of you.
I just wanted to kind of problematize the stress that you're referring to and some of the other factors, with those different groups, and also at least mostly African American patients that you're working with.
Yes.
So there's been some research in Gainesville looking at hypertension, experiences of racism, both direct and indirect, effect on cortisol. So I don't know if you have questions about racism or experienced racism. That could also be affecting African American stress levels.
That's a good point. Yeah, because we may see a reverse effect. Because we're not even, I was talking to one of my colleagues a couple of weeks ago, this whole notion of resiliency. And so for some, having a diagnosis of cancer is a catastrophic event. But if you've been dealing with tough events all of your life, and you have some effective coping strategies already in place. And we know that, especially for minority populations, they present with existing comorbidities. So if you've been managing your diabetes since the age of 29, or if you're hypertensive and you're on different meds, or if you're suffering from heart disease, and the list could go on. I mean, diagnosis of prostate cancer, I can handle that because I've been managing these other chronic conditions. So we're starting to see that as well. And we have to, I don't know if we can, adjust for it in our model, but it's something that we might want to look at later down the line, this whole notion of resiliency. And it may not be as adverse of an impact, as it is with other groups or populations.
I think that I focus a lot on the VA veteran population because in the VA system obviously there is no problem with equal access. So probably one of the shall we say race-specific issues that may be actually better found, which is one of the examples.
You said study of race-specific issues?
Yes.
Okay. Oh, within the VA structure.
There's no disparate access at all.
Right.
And
Yeah.
really, as far as I can tell,
Yeah.
everybody's treated the same.
Yeah. But then there's some studies that have found, and even when access is available for all, there's still disparities.
Well, I mean,
I don't know if it's in the biology or something else.
in our experience, at least some of that is biological.
It is biological.
We learn much together, I can tell.
Oh, perfect. Okay. Awesome. Any other questions? Yes, Dr. Marvella. Sure. Yeah, definitely. And so, it's a multi-level intervention where the iPad is focused to deal with the psychological aspects relevant to the individual, while the navigator is designed to deal with sort of the context that the individual exists in. So to help the individual overcome logistical barriers, whether it's communication or accessing resources and services or communicating with the healthcare provider, the list goes on in terms of some of the issues that individuals may encounter. And so we designed that model to really deal with this notion that it's not all, the focus should not all be on the individual. But you have to also consider the context of which the individual resides. Some individuals are, around great health promoting resources, while a lot of minority populations are around health suppressing resources. That really constrains their progression. There was a paper that just came out by Tom Levi's group that really chronicled that black men are more likely to delay treatment in comparison to men of other racial and ethnic groups after being diagnosed for prostate cancer. And I think they used a data set out of North Carolina, which entails some of the VA data as well. So what's the reason for this delay? Is it because I just don't want to deal with it, or are there constraints in my environment that are sort of inhibiting me from dealing with this issue? And so we think, and we're hypothesizing, that our model could address both. Those individuals, those issues are at the individual level, but then also in the social context. And I have a full listing of all of the content for the app that I'm more than glad to share with you as well. And a lot of this information, if you note, was derived from prostate cancer patients themselves, in part of the evidence that has been generated over time through research studies. And so really incorporating the voice of the patient, I think, is important in the design of interventions as best as you can. Right. All right.
With this,
Sure.
various approaches. Can you share with us some of the ways in which you approach that? How did you capture that information from the community? How did you sort of see or assess how you could evolve and integrate community competence or their input into
Sure.
the development of the tool,
Right.
ultimately the act?
So we allowed the tenets of the community-based participatory research framework to guide us in that process of, one, developing relationships with the community, especially the community that you're targeting. And then not only sitting down and having a series of meetings with them in the design of the intervention, but allowing them to utilize intervention and just give us feedback as to the reality. Will this work or will it not work? And so really incorporating, again, their voice in the design of the intervention. We're just the technicians, right? So we know the theories, we know the concepts and the ideas, but in terms of how it should be presented, that's for the community. They're the experts. They know what works best for which groups, when, how, where, context, whether it's in a church, whether it's in a barbershop, a beauty salon. They know who to target. We had some men say, well, you should target this toward our spouses or to the women in the community, because they serve in more of this nurturing role, this more caregiving role. And so we incorporated that piece. And so we attempted to include every aspect of it, this whole notion of familialism, which is a social construct, this whole notion of religiosity. And so a lot of people wanted to see their spiritual views reflected in some way, somehow. And we heard that. We published a couple of papers on spirituality and health among cancer survivors and presented it at APOS about 3 years ago. American Psychosocial Oncology Society. And so we understand that, for certain groups, these factors are extremely important, and I think for Hispanics as well, this whole notion of religiosity is extremely important in terms of how they progress across the cancer continuum. So to develop an intervention that totally negates the cultural aspects decreases the receptivity of that particular intervention. So it's extremely key for us to really sit down, not through a quantitative evaluation of this population, but through a qualitative, to really hear the explanatory side of how we should build this intervention and why we should build it this way.
Telomerase, you mentioned it from peripheral blood.
Yes, yeah, and so we will. We're planning to do that.
So the telomerase studies you mentioned, they were done on peripheral blood or cell type? Or
In blood, yeah, in blood.
The white blood cells or just?
It's not really my area of expertise, but I'm collaborating with one of the smartest persons I know, John Park, at Moffitt Cancer Center, molecular cancer epidemiologist, and he's actually heading up that piece. So he's one of the key personnel on the study. Trying to incorporate transdisciplinary approaches as being advocated, right? So you have the host of disciplines at the table, from the computer programmers to the bioinformaticists to little old me, the behavioral scientists, to, again, molecular epidemiologists, and you want to try and make the team work, and, right, exactly. He does that as well, John Park, and so, we were able to put applications together, and, everybody spoke a different language. We all had our jargon from our field, but somehow we got the application completed and submitted. But it took a while. It took us a year to do it. Yeah, and we had to have some professional humility in the process because everybody thought their approach was the best way to go. So, but it was fun. I'm sorry. Yeah.
And that's the only way they know about the symptoms. They don't know that because of someone educated them about prostate cancer. They just know that they should go to the doctor because that's part of their family history.
Wow, that's good. Yeah, that's a great question. Well, so we're actually looking at it from the time of diagnosis through survivorship, because we're really interested in sort of why is there a delay in care-seeking behavior on the side of the patient. But that's an excellent point, because one of the risk factors for prostate cancer is family history, and other than ethnicity, and then just getting older. And so it's extremely important, for individuals to have that knowledge of their family history. And for those who don't, what are they supposed to do? How do they get that information to activate a preventive lifestyle right? And so you bring up a good point. So how would one get that information about what they should be doing for prostate cancer, or even having knowledge of what's in their family? You know? So are you a summer student? Wow, that sounds like a great project about just education models for prevention in community-based settings to increase awareness, increase people talking. They could. They could, yeah. That could be a campaign on the iPad. You know your family history. You know, as you have family reunions or different gatherings throughout the summer vacation, have these discussions beyond how school went, how everybody's doing. But talk about what's in your family and what things you can do differently. You know, cut back in terms of, different dietary habits or, the bad ones versus the good ones, and increase physical activity, and, the list goes on. Some type of behavior modification, but that's extremely important, knowing what's in your family history, because, again, when prostate cancer is caught early, it's 100% treatable, right? And people are living past the 10-year mark, which is great news, but it's getting in there early enough, just like with all diseases. You know, if you wait too long with your diabetes, you're going to undergo neuropathy and soon amputations and kidney failure and blindness. So you got to get in there early and develop a management strategy and work with your healthcare provider. So you're sharing information. It's a relationship, not just do this, do that. Because a lot of people don't respond to that model, but it's sort of a two-way, bi-directional. And you have another follow-up? All right. Okay.
And we're doing something like that now, like educating people in the community. But after looking at some results that we brought back, like in evaluation, I see that most of these people are females. And these people are being educated with prostate cancer, but those are not the people that are suffering with prostate cancer. So I feel, and like how you mentioned earlier, that males are a specific breed, y'all are different.
Unique species. All right? It's that XY. I guess you could say that. I slow down. Hey, help me out, man. Right, there you go.
They get those symptoms, but they ignore that. And so
Sure.
it's like another thing that you explained, they don't talk to their spouse. So their spouse knows the information and
Right.
knows those symptoms, but they don't go to their spouse about what they're going through because they're not educated, or they don't realize they're suffering with prostate cancer or anything severe like that. So they don't talk to their spouse, so their spouse is not telling them, well, let's go to the doctor to make sure, because that's one of the symptoms for prostate cancer.
Sure.
So I feel like there should be a way to possibly reach out to more African American men and let them know that there is a thing called prostate cancer, and
Sure.
these are some symptoms, and maybe there should be a way for them to get to medical support and for somebody to support them. Because I have a granddad, and the only reason why they went to the doctor to get checked is because their father and their brother suffered from prostate cancer and died from prostate cancer.
Oh, man.
So they went and realized they had prostate cancer.
I
So
see.
they didn't know that, and they could have been suffering with it longer than
They needed
should
to.
have been.
Yeah.
And so that's one reason why they went, is because they know their brother died from prostate cancer. So
Wow.
that's the only reason why they went and got checked
Yeah.
and found out that they had prostate cancer.
Yeah. Yeah, I mean, I think your points are, very well received. And, we need to come up with better models of really targeting men, or even the family structure, where you target the women, knowing that the women will share, that information throughout their, church or throughout their community or throughout their family. And so you have to evaluate different models because every community is different and the dynamics are different. I know Dr. Luque and I tried to educate men in Tampa. And, some men, received our message. Then others are like, is there something else for me to have to worry about? And looking at Maslow's hierarchy of needs, hey, I got the lights to keep on, I have bills, I'm trying to maintain my job, life is happening. And so you want me to go and find out if I have this issue, and then I have to deal with that. And so you have to, meet them where they are. And then, again, I think that's where the navigator may come in to help them move across a continuum, to help them address some of those issues. Because fear is very resident. I mean, fear is real. That's a real issue, and I think we don't address it enough in a lot of our interventions. But people are fearful because the moment you tell somebody they have cancer or you have an abnormal cancer screening, am I going to die is the first question. Cancer fatalism. And a lot of people hear that more people die of cancer than they hear that people are actually surviving. That, cancer mortality is on the decline for most of your top cancers. That's the great news, so we are making advances. But they don't hear that message in the community. It's more about, oh, you have a death sentence. So we have to even change the way we talk about these issues and present it in a manner where you're not misleading, but you're just presenting the evidence. And that we are making advances in how we're treating cancer. We are making advances in how we're disseminating education and information. And we are making advances in terms of how we're caring for survivors once they come out of being treated for cancer. And all these are very important issues to recognize because there's been a tremendous investment in this nation as relates to cancer from the moment they declared the war on cancer over, 50 years ago? But that message isn't coming down to the community level. So when people hear, you may have cancer, it's paralyzing. And we're saying, all right, go in there and get it treated. It's fear stopping them. So how do we adequately address fear? And again, that's more work to be done.
Well, I don't know if this would help, but perhaps starting at an earlier stage in life.
Oh, wow.
For example, going to high schools and teaching about this to students where they know that this might not be a problem right now.
Yes.
But that this is something to look, not forward to, but like to look out for.
Sure.
And then when they know what it is and they know how to deal with it, later in life when they do get it, they're more prepared.
Yeah. I mean, that's right. But I mean, that's an excellent perspective. I was at NIH last week for a 2-day workshop, and we worked on the science visioning process, where we were actually working on the health disparities research agenda for NIH-wide. And a lot of people advocated for the life course perspective. Now, how that is actually implemented, there's a lot of variance in the literature. But a lot of people are advocating for the life course intervention model, where you're intervening much early on and developing these habits and dealing with social context and how to effectively interact with your environment, and then understanding who you are and your biology, and then looking at that over time. So, I mean, that is a model that a lot of individuals are turning to because they're realizing that behavioral modification at the age of 50 or 60 is maybe a little too late. I mean, we try, okay, but a lot of people are set in their ways, and they'll tell you that. I live this long. If I have to die of something, it will be that. And that's what they tell us in the community. So we respect that. We respect where they are. 68 years old, I think it's young, but others, they're like, hey. And so you respect where they are. So, but intervening at a much earlier age, that's a good perspective. And I think a lot of people are interested in that model as well.